what I'd like to talk to you about is the whole challenge of trying to use this natural experiment, this opportunity of purchasing a great piece of software, namely an EHR, but making it useful for clinicians and patients, and ultimately quality and value of care. I'm going to go back here just 1 second to before we launched into the redesign with the Epic tool. The green ovals show where shared decision making sat kind of outside of the clinical flow for what was in the clinic. It was down the hall. And in the clinical flow, there were patient questionnaires that were deployed before each visit, collecting health history, social history, and some of the actual pain questions and function that was as a baseline. But the decision-making questions around their knowledge and their values and their preferences were delivered on a paper questionnaire. And we said, wouldn't it be great to bring these together? They're both question sets that are relevant to that patient and their knee surgery. Let's see how we can combine collecting the patient's baseline health data as well as their baseline knowledge and preferences. So what we did was a high-level flow chart of what we had hoped the ideal process would be. And the red circle is moving the decision aid from where it was sitting here before the Epic implementation. In other words, you have your first office visit, you're sent down the hall to pick up the decision aid, down to, or upstream rather, to before that first consult with the specialist. That was based on trying to think about engaging the patient before they came in. We did a pilot with primary care docs, of which about 30% of the referrals came to the specialty clinics, so that we had a good opportunity to try this out. And when a primary care doc in the Dartmouth Hitchcock system found the appropriate patient, that there was a question of the osteoarthritis of the knee and possible candidate for surgery, before the consult actually occurred, they said, let's do the decision aid with the full video and printed materials and the baseline questionnaire about knowledge, values, and preferences. So that had been trialed and was successful. So we said, well, why don't we build this in before the visit and have it occur in the patient's home, and the scheduling secretary would be the key point in person in the process to see that when the appointment was being scheduled, the notification to the Center for Shared Decision Making was occurring, so that the decision aid would be sent out to the patient. So we took advantage, and in the group health presentation, they are also on the Epic product and named their secure patient portal My Group Health. Well, we are My DH for Dartmouth Hitchcock for our secure patient portal, where messaging, appointment, and prescription renewals can take place, as well as having messages sent with attachments of electronic surveys. And so we decided to use this as a vehicle for deploying the patient questionnaire that would accompany or follow subsequently the whole sharing of the decision aid and the materials in advance of the surgeon's visit. This survey and message that goes to that prospective patient who has an appointment is timed so that it is in advance of the clinic visit, and it also points to an important principle that we are collecting information from the patient, and then when the patient completes their survey, it comes back in through the secure patient portal and lands in the medical record with a point of care report for the doc. And that includes patient self-report, again, of their pain, their physical function, a list of their comorbidities and previous health history, as well as questions around the knowledge from which they gained using the decision aid, their values, their preferences, the expectations that they have of the surgery, as well as if they are leaning toward, expectations of treatment, and whether they are leaning toward surgery or not. Now, this resulted in kind of a opening up of an opportunity to say, well, are we using our resources within the clinical team in the best way that we can? And started to re-examine the actual job function, with the principle being have these individual members of our clinical team functioning at the top of their role. And so a medical assistant can certainly be part of the survey process by bringing in the report from the little message box into the clinical record. That's a function of rooming the patient. The nurse can do reviewing the results for perhaps more detail of the previous history and some of the pain and function questions that the patient answered. And so when the surgeon comes to the room, the redesign, and this is what really appealed to the clinician, was that there were 3 points in the process where they and only they were truly needed to have input to the documentation and the discussion with the patient around the decision and the options for the anesthesia or the prosthesis and so forth, if they were to decide to go forward with surgery. So by mapping out the flow here and looking at who was doing what we did was take the prior workflow and construct an ideal workflow with team assignments or clinical team assignments that were negotiated, trained, and a change from what folks had done in the past. Now, rather than Carol and Kate and I helicoptering in to this redesign process, these team members or a representative of each role of these team members came to the table and had part of the discussion about that change in their role or the place in the workflow and how things really worked compared to how we put it down on paper. And the surgeons were, I have to say, really pretty good about devoting 1 to 2 hours once a week, every Monday afternoon, to this committee process. Our goal was to have an ideal workflow with certain points in the workflow process where we needed to have our clinical programming team doing the EPIC installation do something special to make it work in the orthopedic clinic. Take the toolbox and build something particularly relevant to orthopedics or this knee surgery. And we also had an ulterior motive of making certain that the data that was entered at different points in the process could be saved and data mined later for feedback of results and performance over time, not only of uptake of these pieces of the process, but actual patient outcomes and the effectiveness of the different treatments. So just to make this real, rather than see only a workflow map, what we did was, here is the EPIC tool, built a place where the medical assistant who was rooming the patient could look at an inbox and bring in the results of part of the whole questionnaire that was answered by the patient. Now, here's one glitch. If the patient had not responded to the message, had not filled out the questionnaire in advance of the visit, then there was time in the waiting room to use a kiosk or a touchpad. And that was often a disruption in the workflow or resulted in a delay in the clinical flow process. And trying to mitigate that was a challenge. The expectation that patients would, in fact, need some assistance to use this technology, some of the team members kind of glossed over, and some said, well, this is a real resource need, and you have to have a good impression on day one. Well, it's been kind of a cajoling of, well, maybe this time this receptionist can help, and maybe this time this medical assistant can help a patient, and not a really nicely codified process for how to make that work better. Another part of this process would be how we built, there's a long, I'm going to just advance one slide. The results of the questionnaire are lengthy and not very pretty. They're single-spaced. Here's the question, here's the response. But what we had our EPIC programmer staff do for us is to pop out the most important responses to the questionnaire to the front page that the clinician sees, so they're not clicking around searching for the most important information. The other part here was some of their scores or how sure the patient felt about their decision. And that was, we would have liked to be a hard stop. If the patient was unsure, then you go no further. And depending on how the clinician, we just didn't do that for the reasons of not wanting lots of pop-ups, and at least in first deployment of this medical record. Instead, each clinician has embraced that part of the information a different way. But before an informed consent is signed prior to the surgery, we expect, and the clinicians have taken the role to resolve that uncertainty, answer the questions, respond to any explanation of risk, benefit, if there are still any lingering questions that the patient and the family may have prior to consenting the patient. Now, this is a format and information in the record for each of the visits with a clinician prior to the surgery, if they choose to have surgery, and it's usually 2 to 3 visits. So you can actually see the progression of information across subsequent visits for the level of certainty, the level of knowledge, and so forth. We made a very clear decision ahead of time to have our results of this process be transparent, both internally and externally. And we've probably done, as Kate showed you, a good job showing for the practice how much of the shared decision-making tools were used in the uptake over time. The aggregate results that Stephen put together, we actually post on the public website for the medical center on the knee arthroplasty or hip arthroplasty page, where we are able to say among the patients who watched the decision aid, did they know the available choices and so forth? Were they feeling sure that this was the best choice for them? 75% said yes. 19%, or basically 1 out of 5, changed their treatment choice. Now that could have been either from being unsure coming in to a decision, or from changing the decision of no surgery, nothing for me, don't want anything but medical management, to a surgical decision. But still, that gives one pause that 1 out of 5 patients, this actually had them make a cognitive change to what they expected when they came in. And finally, this is the question that final question that is popped out on that EPIC page of the clinician summary, and people who felt they had sufficient support to make the decision. And 1 out of 10 did not. So that, again, is a metric that we can be working on to improve. Now, the internal results, as I said, we appear to be doing a little better job on the external. Now that we converted to EPIC, we have yet to see our performance results of deploying surveys, how they're being used, what the scores are for those patients in aggregate over time. And it's simply the fact that you put up a new piece of software, and the reality is there has to be a stabilization period, and the reporting function of the software installation is the last priority. It has to be functioning for documentation and patient care. So we don't quite know, and anecdotally we hear that patients are receiving the surveys. The decision aid distribution is not quite where we want it to be. It's still a little closer to the clinician visit, not prior to the clinician visit, as we had hoped and designed. And finally, the good news is that as this workflow was implemented, and it was bumpy, there has been a buzz that nurses love being in clinic in those days that they are assigned to clinic. And some of the physician and the associate providers are frankly surprised and thrilled at what nursing is actually doing in their role that they had not realized as part of the functioning of the team. So a wonderful consequence in the role redesign was trying out some new processes and having some very positive results. Now, I will say that the fact that there's no reporting yet is a real disappointment to the leadership, right down to the individual clinician who from day one said, if I'm going to spend time putting in this information, I want to be sure I can get it out. Now, they can get it out one patient at a time, but they do really, truly want to see outcomes over time and in aggregate for their practice and for different strata of their practice. Those patients who receive a single primary knee replacement versus those patients for whom they do a bilateral simultaneous knee replacements, and to be able to follow those. And that's not too, in not too distant a future.